Our guest speaker whilst I tinker with the IT. Bear with me.
Okay, great. Thanks, Tom.
Okay, that's it.
So we're privileged this year to have Moira Whyte present our fifth annual DCAT lecture. She joins a line now of distinguished DCAT lecturers. So we've had Sadaf Faruqi, Sharon Peacock, Andrew Hattersley and David Adams, and the fifth is obviously today. Moira is a Professor of Respiratory Medicine at the University of Edinburgh and the Director of the MRC unit there for inflammation research. I can think of no one better really to give this lecture, as she really has clinical academic training at her core. She's chair of the MRC clinical training panel. She runs the Edinburgh Clinical Academic Track clinical PhD programme, and she's recently appointed head of Edinburgh Medical School. So we really are very fortunate to have her present to us today. And she's going to give us a lecture on how does oxygen regulate inflammation and host defence. Over to you, Tamara.
So obviously my thanks to Ewan for that very kind introduction, and also for inviting me to give this talk. Always slightly daunting when you hear the previous speakers and you think, oh, so-and-so's a very good speaker and so is someone else. My background is in respiratory medicine, so although some of the processes that I'm going to talk about are very relevant across many, many different types of disease, the examples that I draw are going to be mainly focused on the lung, but I hope that those of you interested in other areas will be able to see the parallels between what I'm talking about and what you yourself are interested in. So my research interest for the last more than 20 years has been in the process of inflammation, and it's something we learn about very early on in medical school, and we're reminded as a bit of history and amongst our lecturers that the process of inflammation was described 2 millennia ago by Celsus, looking at the effect on the skin of having a thorn inserted, and he described the process of inflammation as resulting in calor or heat, rubor, redness, turgor, swelling, dolor, pain. And then later on, Galen pointed out that the inflamed organ was typically one that had also lost its function. And, oh, I've done something dreadful there. Just bear with me. Here we are. Nope. I think I will. No, I'm all right, I think. If I stick to this, I can't do much harm. And over the last century, really, the components, particularly the cellular components of inflammation, have been studied in great detail. And there are a number of complexities and a number of different types involved in inflammation. But essentially, injured tissue, whether physical injury or injured by infection, produces signals that cause the recruitment of white blood cells, leukocytes, to leave the circulation and to travel to the injured tissue, where they have important roles both in eliminating whatever the insult was, so killing bacteria typically, but also in setting up the processes that are crucial for tissue repair. And it's important to stress that leukocytes go beyond just killing bugs to actually set up the cellular processes that are required to heal a wound, whether it's in the skin or in the liver or in the lung. And all these processes are very ancient, they're very evolutionarily conserved. And so, for example, we know that the most primitive organisms have cells that we would recognise as macrophages. They live in tissue and they're able to eat bacteria and promote wound healing. By the time you get to organisms that have neutrophils, that have a circulation around the earliest vertebrates, and I'm going to show you one slide that is actually data from zebrafish. So from very early on in evolution we can recognise macrophages, and then later on we can recognise the neutrophil, which is the cell most highly adapted to fighting infection, but has important and emerging roles in tissue repair. So the reason we as doctors should be concerned about inflammation is for two reasons. The first is that inflammatory processes underpin so many of the diseases of the 21st century. And, cardiovascular disease, rheumatological disease, increasingly neurological disease is recognised as having important inflammatory origins. So inflammation is important, and also we have been very bad over the last century at treating inflammation effectively. And I just drew up this little table thinking about how we treat inflammation in the lung. And I'm not talking about allergic inflammation, I'm talking about neutrophilic inflammation. So we've had steroids since the 1950s, we've had inhaled steroids since the 1970s, we've had non-steroidals emerging in the 1970s. None of these are effective in conditions characterized by neutrophilic inflammation. Anti-TNF has turned out to have a very important role in rheumatoid arthritis, but is ineffective in other common inflammatory conditions. And also the newer biologics, although many of them are showing efficacy in rheumatology and some other inflammatory conditions, none of them yet has really had significant impact on major chronic lung diseases. And the pharmaceutical industry pipeline is also pretty depressing, actually, in that if it's unfair to pick perhaps on GSK, but I think this is interesting. This is their pipeline as of March 2016. And when you look at the new drugs they have in development for COPD, the commonest chronic inflammatory lung disease, what you actually see is that many of them are modifications of old drugs, and very few of them, with the exception possibly of PI3 kinase inhibitors, are novel approaches to neutrophilic inflammation. So we don't have effective drugs, and at the moment the pipeline is not great. So you can see why this is a fertile area for thinking about novel approaches to treating inflammation. Now I just put this up because I'm going to show you a lot of slides in which a process looks really quite sterile, quite non-dynamic. But this is what really happens in vivo. So this is zebrafish data, and what you have is a carpet of red bacteria, and you have green neutrophils eating them. So I just want you to see how very good neutrophils are at eating bacteria. So I could play that again, but I won't. I find it. So the other issue with treating neutrophilic inflammation is a difficulty that I've already alluded to. That on the one hand, we know that neutrophils are critical for clearing infectious agents. So this is a patient with pneumonia, and the white patch represents areas where the lung, instead of being full of air, is full of white blood cells, principally neutrophils. If you re-X-ray the same patient only a few weeks later, the bugs have gone and the neutrophils have gone. So neutrophils have very effectively dealt with that infection. And we know that even before the advent of antibiotics, people, generally speaking, could survive pneumonia. But we also know that neutrophils and their toxic contents of enzymes and oxygen radicals are also able to cause very extensive tissue damage. And the disease that we think about a lot, of course, is COPD, principally caused by cigarette smoking, but not exclusively, and it causes destruction of the lung tissue that we refer to as emphysema. So we have this paradox in thinking about the neutrophils, that on the one hand we need competent neutrophil responses for when we experience infection, but on the other hand we know that neutrophils underpin the pathogenesis of many of the diseases that we deal with in our clinical practice. And these are big clinical challenges. So I just took some figures from the global burden of disease, and in the UK, the numbers of people who get pneumonia every year and the numbers of people who suffer from COPD are very significant indeed. So, My research story goes back a long time now, 25 years, to when I set out to do my PhD, and at that time I was based at the Hammersmith Hospital in London, and I had two supervisors, Chris Hazlitt and John Saville, who had demonstrated that neutrophils spontaneously undergo apoptosis, programmed cell death. And that was a very key discovery in the inflammation field at the time, because people had thought a great deal about how neutrophils enter tissue, but people hadn't really thought about how they are disposed of subsequently when an infection is dealt with, for example. So the concept that actually neutrophils have an inherent suicide program was very interesting in explaining how inflammation resolves, but importantly, potentially giving a way in of modulating this process. So John and Chris went on to show that actually the neutrophil dying was important in clearing neutrophils, but it also modified the outcome of all the subsequent inflammatory responses, in large part because apoptosis is a specific signal for neutrophils to be engulfed by macrophages, and this alters the macrophage cytokine response to a pro-resolution healing phenotype. So you can think of apoptosis not just as a waste disposal system, but also as something that then reprograms the whole of the subsequent immune response. And so we began to wonder at the time when I undertook my PhD that if we thought of inflammation as having an onset, it has a peak, and then it has to have a resolution phase, that actually maybe the way in which neutrophil apoptosis is regulated is crucial to that inflammation phase of resolution. And taking it a bit further, you can speculate that if neutrophil apoptosis fails or is not engaged at the appropriate time, then that could be a substrate for persistence of neutrophils and for a chronic inflammatory response. So that was our thinking. Now, you can also, so what we're saying here, and how I want you to think about it, is if you think about a neutrophil, our neutrophils spend the vast majority of their time circulating, and most of our neutrophils will live and die in the circulation in vast numbers without ever being recruited into tissue, because we don't get that many injuries or significant infections. But much therapeutic energy has focused on preventing neutrophils from exiting the circulation and going into tissue. The disadvantage of that is clear, that you limit the ability to deal with infection in neutrophils if that is your therapeutic approach. So what we went on to focus on is, could we regulate this conversion from a viable neutrophil to an apoptotic neutrophil? And over the years, we've identified many different pathways that are potentially important in determining the onset of neutrophil apoptosis. And I'm not going to talk about many of them, and today I'm actually going to focus on the role of oxygen in regulating this process. But we've looked at many bacterial and host factors that regulate this pathway, the commonality of the signalling pathways that they use, and how we could regulate this therapeutically. Okay, so an important paper in the field was that from my colleague Adriano Rossi about 10 years ago now, and what he showed was that if you took a group of compounds that actually are pharmacological inhibitors of a particular enzyme family, that you can actually drive neutrophils to earlier apoptosis. And he was able to show that in a number of different models of inflammation, both pleurisy and lung inflammation, that actually by accelerating neutrophil apoptosis, inflammation gets better. So that's an important proof of concept in the field. The snag with this data is that these drugs also accelerate the death of neutrophils in the blood. So they're not specific to the population of inflammatory neutrophils that you would really like to target. So we've been interested in thinking about factors that are only applicable at the site of inflammation and won't apply to the circulation. And I think all respiratory physicians are interested in oxygen, but the lung is particularly interesting because in health it is a very well oxygenated organ. So if we sometimes talk about the oxygen cascade, so the air that we breathe in is obviously highly oxygenated with an oxygen tension of around 20 kilopascals. By the time it reaches the alveolus and is transferred into the arterial blood, we're down to around 12 or 13 kilopascals. By the time it's been around the circulation and you look at mixed venous blood, it's about 7 or 8 kilopascals. But importantly, in solid organs such as the lung or the liver or the kidney, the usual oxygen tension is only about 3 kilopascals. And we know that in the lung, in areas of dense consolidation, such as pneumonia, that the PO2 can drop in the tissue, can drop very low indeed. So healthy lung is obviously very well oxygenated. In the example of pneumonia I showed you, where the alveoli are full of white cells and debris, the PO2 is very low. And you can also get areas of regional hypoxia. This is an example of an airway in an asthmatic that's been occluded by a mucus plug. So oxygen levels can vary a lot in the lung, and we also know that unlike other organs, other cell types, neutrophils actually respond to hypoxia, to low levels of oxygen, by surviving. So apoptosis, cell suicide, is delayed by lack of oxygen. So I love this example because it tells us something very important. This is a patient with an empyema, so pus in the pleural space as a consequence of pneumonia. And if you take that fluid out and you put it through a blood gas analyzer, I don't know how well you can see this, but the oxygen level is precisely 0. And yet, that fluid will be full of healthy neutrophils that are effective at killing bacteria. So neutrophils work completely independent of oxygen availability. And if you take neutrophils from the blood and you culture them in an incubator at normal oxygen concentrations, then you can see them by their appearance undergoing the apoptotic suicide program. If you deprive them of oxygen, then they actually live on very happily. You're markedly extending their lifespan. So we thought this was very interesting. It was a factor that would influence inflammatory neutrophils with limited effect on blood neutrophils. And it was also a way, importantly, in which neutrophils respond completely differently from other cell types, so bringing the possibility of some specificity in targeting this pathway. And we know from work of a large number of groups that many of that all cells have the ability to respond to oxygen through activation of a key transcriptional pathway, the HIF pathway, hypoxiainducible factor pathway. There are 2 HIFs, but HIF1 alpha and HIF2 alpha that bind to the same beta subunit. But I'm mainly today going to tell you about HIF1 alpha. And it's known in a number of cell types that HIF1 alpha markedly influences important cellular processes, including metabolism, killing of bacteria, and cellular migration. And in the case of neutrophils, we know that HIF1 alpha is required for that survival signal in hypoxia. So I'm going to come back and talk about HIF1 alpha. So all cells have HIF. The interesting difference with neutrophils, as I've said, is that it's associated with survival. So let's go back to our patient with pneumonia. And I've mentioned already that a patient with pneumonia, the area of consolidation in the lung is going to be hypoxic. But as these patients become sicker and they develop clinical syndromes such as ARDS, they also become systemically hypoxic. So it's a good example of the therapeutic difficulty that we have also. So this progression from pneumonia to ARDS, is also complicated by the fact that you have both infection and inflammation coexisting in the same patient at the same time. So we were interested to look at how oxygen availability modifies the inflammatory response. And I've just chosen to tell you one story, and you'll see at the end that it's not very complete. I can tell you the direction we're going in, but I'm not going to give you one molecule, one answer necessarily. So what struck us is that when patients who are on ICU develop a line infection, a relatively trivial event often, it can have profound clinical consequences in terms of destabilising the patient. And we thought we'd start very gently and take quite a simple model of infection. And what I'm actually showing you, I'm afraid, is the backside of a mouse that has been shaved, and the mouse has been inoculated with a very small number of Staph aureus bacteria, so a fairly typical skin infection. And in a healthy mouse, the abscess evolves over the course of a week, but the mouse itself tolerates the abscess very well. It's not bothered by it, and eventually it goes away. So we took this very localized infection and we said, well, what effect does systemic hypoxia have on this infection? And the answer is it has a very, very profound effect. So we took our mice, we gave them relatively small numbers of Staph aureus, and then we put them either into normal levels of oxygen, so 20%, or hypoxia, 10%, which gives them an arterial PO2 of about 6 to 7 kilopascals. And what we found is that the mice who were hypoxic became profoundly ill. We measure this by sickness score, and we measure this by hypothermia. You can see the hypoxic mice become profoundly hypothermic. And then we had to terminate our experiments because the mice were very unwell. So we were changing what was a relatively trivial infection into a profound systemic illness. And interestingly, this is a graded response. So I think I can persuade you that you can take normal oxygen availability. At 15% oxygen, it's not much different from normoxia. But at 12% oxygen, you can see that score is beginning to shift, and you can see it as well with the hypothermic response. So it's a sort of dose-response curve to oxygen availability. But we struggled hugely to understand this phenotype. We had a very dramatic phenotype, but we couldn't really understand why we had it, because everything we thought of measuring was actually pretty unexciting. So the first thing we thought was, well, maybe we massively upregulate the inflammatory response by making the mouse hypoxic, and it turned out it made no difference at all to the number of neutrophils that we could identify in the skin. It also made no difference at all to the numbers of bacteria, either in the tissue or in the blood, so we weren't affecting the rate at which the bacteria divide. What we did see was a very profound cardiac phenotype. So as the mice became hypoxic and hypothermic, they became bradycardic, they became hypotensive, and they had a markedly reduced ejection fraction. And a clever colleague in Sheffield was able to do echocardiograms on these mice, and you can see that the normal mice, you see the normoxic mice, you see normal cardiac contractions, which you don't see in the hypoxic group. So we were producing a phenotype of cardiovascular collapse, really. And we knew it was a host response because we were able to take killed bacteria and we still got the same response. So we weren't changing something that the bacteria produced that had this effect. And we then spent many months measuring everything we could think of: cytokines, nitrates, oxidative stress, hepatic function, white counts, ATP. Importantly, there was no evidence that we were causing acute lung injury in these mice, which was something we thought was possible. So I'm not saying that these are exhaustive because we haven't done every conceivable cytokine at every conceivable time point, but we certainly weren't seeing an obvious explanation for this data. So we thought, well, is this anything to do with HIF? We know that HIF profoundly regulates neutrophil behaviour, and we had some mice that have HIF1 deleted from their myeloid cells, so it's absent from their macrophages and their neutrophils, and we were able to show that these HIF1 knockout mice were less sick in the context of hypoxia. So that's interesting for two reasons. It suggests HIF is having a role, but actually, despite what was apparently a systemic phenotype of cardiovascular collapse, it looked as if the behaviour of the macrophage and neutrophil population was actually crucial to this systemic response. Again, we didn't alter bacterial numbers. So at that stage, we didn't know whether this was one particular infection in one particular organ, whether this phenotype was pathogen-specific. It was something about Staph aureus, though that seemed unlikely given killed bacteria were effective. And was it something to do with the skin? So we have repeated the experiments in an acute pneumonia model, a model of streptococcal pneumonia, where we did the same experiment, administer the bacteria, and then put the mice either into normal oxygen or into hypoxia. So this is a model of pneumonia in which the mice do become unwell and they become bacteremic. Bacteria escape into the bloodstream. So to summarise this graph, we found that we had the same phenotype of hypoxia producing a profound systemic response with a different bacterium and in a different organ, this time the lung. So we knew that this was something of more general importance. And we were able to show that it didn't affect neutrophil recruitment to the lung, which is all that this graph really tells you. So we had a phenotype in the acute setting, but we found this quite puzzling because we deal clinically very commonly with a condition, COPD, that you'll be very familiar with, in which you can have persistent inflammation. Well, you do have persistent inflammation. You typically have the presence of bacteria in the lower airways, but you also, in patients who are severely affected, have chronic hypoxemia. And these patients are not keeling over the whole time. They're, I wouldn't say happily coming up to outpatients, but they are clinically stable despite the coexistence of hypoxia and infection. And that made us wonder whether the response to chronic hypoxia would be very different from the response to acute hypoxia. So what we did was we acclimatized our mice to hypoxia for a week before we infected them. And what you can see is that actually chronic hypoxia has a very different effect, that if they're pre-acclimatized, they're used to being hypoxic, they tolerate the pneumonia, the skin model much better than if they're made acutely hypoxic. The really striking thing on this slide is that actually if you pre-acclimatize the mice, that effect lasts up to 28 days after you take them out and put them back into normal levels of oxygen. So we are reprogramming the immune response in these mice. And that's true again if you look at the pneumonia model. But what I really want you to look at is how very profound this effect is. So the red line, this is a pneumonia model in which we expect a proportion of the mice to die. What you can see is in the normoxic mice who have pneumonia, about 60% of them survive up to a week. If they have pneumonia and are systemically hypoxic, they all die. If you precondition them, they actually do as well as the normoxic mice. It's tempting to say they do very slightly better. So you're having a profound effect, not just on sickness scores and so on, but also on survival. We were able to show that we could take the bone marrow from pre-acclimatized mice and put it into mice that had not seen hypoxic, and hypoxia, and we were able to transfer this effect. So we were transferring it in the white blood cells, in the leukocytes, and we were able to show that we could also transfer the survival effect simply by transplanting bone marrow of mice previously exposed to hypoxia. Okay, so what we want to know, of course, is how are we doing this? We've isolated the effect to the leukocytes. So what we did, as you often do when you don't quite know what the answer is we decided to look at the gene expression in our different in the white blood cells, the leukocytes of our different populations. And this is a complicated slide, but it has two main messages. The first is that the effect of infection in general is to upregulate a whole load of genes, 550 genes upregulated in the infected mice. The effect of preconditioning is to massively downregulate genes, so we have 975 genes going down as a consequence of the preconditioning. But interestingly, when we cluster our animals according to whether they have been infected or not, hypoxic or not, it is hypoxia that really determines the pattern of their gene expression far more than infection. So hypoxia seems to be very profoundly altering gene expression. We, of course, had some ideas as to what might be altered. I apologise for this slide. There is no prospect that you can read it. Suffice it to say, we did quite a lot of analysis of this RNA-seq data, and what we pulled out is that, not to our surprise really, HIF1 alpha and its target genes were being markedly downregulated, and one particular metabolic pathway, the glycolysis pathway, which we know is importantly regulated by HIF, was also being significantly downregulated. So this just is quantitative PCR data to confirm the results of the RNA-seq data, to show you that if you compare hypoxic mice to normoxic mice, you see upregulation of HIF1 alpha that is markedly downregulated by preconditioning to hypoxia. We can see the same pattern in HIF target genes. I've just shown you two, but we've done many more, and they all show the same pattern. So HIF is downregulated and its targets are downregulated. What we are only beginning to try and understand is how this metabolic reprogramming that we suspect is going on might actually be working. Because when we went back and we looked more closely at the mice from our pneumonia model, we had some samples that we took just before the mice were sick enough to have to be culled. And what we were able to show is that their blood glucose of those who were sick was very much reduced compared to the mice who looked a bit healthier at the time. And when we looked at the effects of hypoxic preconditioning, we were able to show that glucose levels go down, as I've just told you, in infected mice who are hypoxic, but if they're preconditioned, then the glucose levels do not fall to the same extent. We're actually doing something quite profound to the mice by preconditioning them, which we don't fully understand. So the preconditioning mice, although they survive the infection better, they lose weight, and they lose, but importantly, they retain certain types of fat. They retain their intrascapular fat, which we've been able to measure, and it looks as if the preconditioning is producing really quite a profound metabolic phenotype. It's clearly about more than glycolysis. It's about fat utilization, and it's also about utilization of glycogen stores in these animals. And when we went to look back at our HIF1 deficient mice, we were able to show that the HIF1 knockouts actually maintain their blood glucose levels better than the wild-type mice exposed to hypoxia and infection. So we are revealing quite important metabolic disturbances in these animals. So what I've told you about in work that is very much ongoing is that we've identified a phenotype which was completely unexpected to us when we began, where combining trivial infection with hypoxia results in a profound systemic phenotype characterized by cardiovascular collapse and by mortality. We've shown that HIF1 alpha plays an important role in this because if we delete HIF1 alpha from the leukocyte populations, we can protect against the hypoxia phenotype. Perhaps more interesting, though, is the way in which this process of preconditioning to hypoxia is providing substantial and maintained protection. And that this protection is again associated with downregulation of the HIF pathway and of glycolysis, and we know that this is dependent on the white blood cells. So our hypothesis is that actually the utilization by leukocytes of glucose is so profound with this juxtaposition of infection and hypoxia that it is essentially diverting glucose from other tissues. And we have, I'm sorry, I've had a glitch making up my slides, but we've been able to do FDG PET scans on the mice and been able to show that in the mice with hypoxia and infection, you see no glucose uptake in the heart. If they're preconditioned, then you do see this FDG glucose uptake. So we suspect that the cardiac phenotype that we see is a consequence. This is maybe oversimplifying it, but we think it's a consequence of lack of glucose availability systemically and utilization of those glucose stores by the leukocytes. So what is a very reasonable question to ask. Why do we think this is important, and what are we going to do next? So we are trying to understand if the mechanism of HIF protection is as simple as reducing glucose utilization in these animals. I suspect it isn't, and that there are other metabolic pathways that are also important in this regard. We've shown that HIF protects both acutely and chronically, but we don't know whether the effects of HIF in the two circumstances are the same. Has this got any clinical relevance? Because clearly you're not going to put humans in a hypoxic chamber for a week in order to downregulate their inflammatory response. So clearly not in that case, though I think it's important to say that we're currently working out what the minimum duration of preconditioning is that you need to downregulate these responses. And the answer is that it's hours, not days. But, we don't know whether it's short enough that you might say to somebody undergoing a surgical procedure who's at high risk of ARDS, having an esophagectomy would be a good example. If you spend a few hours in a low oxygen chamber, this might be beneficial. What we think obviously is much more likely is that we will approach pharmacological manipulation of these pathways. So we know that we cannot completely inhibit HIF1 alpha because if we do so, then the infection response would likely be inadequately controlled. So we're very interested in understanding the downstream targets of HIF that are actually crucial for the cardiovascular phenotypes that I've told you about. So this is very much work ongoing, and it's work where clearly the expertise in metabolism in your university could be very relevant to the sort of things we're trying to find out. So I've summarised a great deal of work from a lot of people, as you can see, and a lot of collaborators, but there's two people to particularly highlight. So Rebecca Dickinson's an MRC training fellow who has done the pneumonia model, has done the RNA-seq analysis, and is currently writing up her PhD. But the observation was originally made by another training fellow, Roger Thompson, who did the very first experiments with staph and hypoxia. And my partner in crime, and very much the leading light now in this area, who will take things forward, is Sarah Walmsley, who's a Wellcome Senior Fellow and we share a lab. And she has been working a great deal with collaborators in Leuven, Peter Carmelite and Max Mazzone to understand in much more detail the metabolic shifts within neutrophils that occur in hypoxia, but that's very much her story, not mine, so I'm going to stop there. So, thank you all very much for your attention.